Next speaker will be Professor Nicolo Bizzarri from Rome, Italy. His talk will be about management of low-grade serous ovarian carcinoma.
For this one, because I prefer, yeah. Thank you very much. So it is such a great honor and pleasure for me to be here, and I want to thank you all and the organizing committee, Basel, for having me here. Is it working? Oh, thank you. So today my topic is about management of low-grade serous cancer, and this is my outline, and I will go point by point to discuss about each of these points. Why we should discuss about low-grade serous. Low-grade serous is a rare entity, 10% of serous cancer. Just remember that ovarian cancer is a rare disease. So this is very rare. Develops slowly over a long period of time in young patients with a different natural history because, as we just heard, it can arise de novo or following diagnosis of tumor with low malignant potential. And it does not appear to be part of the syndrome related to BRCA and BRCA2 syndrome. You can see here what I was saying about the comparison between low-grade and high-grade serous tumor comparing to different clinical and oncological outcomes. You see here young patients, frequency is much lower, positive familial history, rare chemosensitivity, and longer median PFS. Look at these curves, quite impressive. Look at the low grade, which is just the full line. It's much above both for PFS and OS. And this is an analysis of stage 3 and 4 disease. My job today was very much facilitated by the recent publication of low-grade serous ovarian cancer, an expert consensus, which was recently published in the International Journal of Gynecological Cancer. There was a gathering of experts in the field, mainly from America, in 2022, and they delivered a consensus statement, which the statements were developed based on questions and ensuing discussions. These are the topics that were covered by the experts, and you can see that they touch every single aspect of the low-grade serous management, starting from pathology, translational research, epidemiology and risk, initial management, recurrent disease, clinical trial and future research, and very interestingly and importantly, the patient's perspective. So here you can see the definition about low-grade serous. We had a previous talk which was really, really important and propedeutic to this one because the consensus agreed on defining low-grade serous as an invasive serous neoplasm with low-grade malignant features. A non-invasive low-grade serous carcinoma is not accepted anymore. And then, as exactly just we were discussing in my previous talk, in the previous talk before me, non-invasive implants appear to confer at least 15-20% increased risk of subsequent low-grade serous carcinoma. It is a very rare disease, and this needs to be highlighted. So for this reason, it is crucial that it's referred to tertiary and referral centers. We just mentioned about the non-link with the BRCA mutation. So there is no evidence suggested that this disease is driven by such mutation. However, the recommendation from the experts was that all patients with low-grade serous carcinoma should undergo germline testing consistent with the overall population of patients with epithelial ovarian cancer. These are the main prognostic factors driving the survival. Overall, the three main factors can be summarized in age, in residual disease at the end of the surgery, and in the presence or not of MAP kinase alteration. So when we divide surgery according to early stage or advanced stage, we need to deal with different situations or in comparing to the contralateral high-grade serous. We know that in low-grade serous, the number of lymph node involvement, is quite rare. Even though in this series, in this report, that's not fully the case, because they found that this is a German study, and they found 5 cases in their series of low-grade serous ovarian cancer, early stage, apparent early stage, which were staged with lymphadenectomy, and they found 1 positive case with lymph node positivity. So 1 out of 5 is 20. This is over a lot beyond the median number of lymph node positivity in low-grade serous. In fact, if we look at a larger series, we see that the incidence of positive lymph nodes in low-grade serous is 10.7%. And if we look at the patients who had just been upstaged only for the lymph node positivity, this drops down to 5.3%. But if the question is if this is translated in any change in survival, the answer here is no, at both for PFS and OS. A recent systematic review of the literature was done to look at the incidence of lymph node positivity in low-grade serous ovarian cancer, and you see that there are few reports reporting this, and overall the number of the rate of positivity was calculated to be 12.6%. The upstaging due to lymph node metastasis alone, though, was 10.5%. So basically, this is it's difficult to interpret, because some people could say, "Oh, it's not so low. Let's do the staging to all these cases." Other people could consider low. So I think it's about discussion with the patient about pros and cons of doing this surgery, because this surgery could also drive to important complications. Another study showing that actually when you do a lymphadenectomy in patients with low-grade serous ovarian cancer, there is no impact on survival. Despite this, what is interesting to me, this study included both advanced and early stage cases. It's interesting to look about the survival analysis in the early stage, because we know what happens with the advanced stage. And in the early stage, there was no impact on survival. But only 17 patients in this study had stage 1 and 2. When we talk about early stage, of course, we encounter the clinical situation of fertility sparing surgery. And this was also discussed during the consensus conference. And the outcome was that if a patient is keen to undergo fertility sparing treatment with early stage low-grade serous ovarian cancer, the opinion was that it can be considered safe only in stage 1A to 1C1, not other stage. At the moment, this is the recommendation. Regarding advanced stage, we cannot stress more the concept that every single gynecologic oncologist do about the importance of achieving complete gross resection of disease by cytoreductive surgery. This is crucial. You can see here the curves, both PFS and OS. There is a massive difference when you take out all the visible tumor, when you leave tumor behind, and when you leave gross tumor behind. So if we categorize this, you see that there is an important difference when you leave tumor at the end of the surgery. So complete gross resection should be achieved every time is possible, considering that this disease has a lower sensitivity to chemotherapy. So the resection should be still considered even in the cases where we think that a minimal residual is left. Okay? So I stress the different concept compared to high-grade serous, where the high-grade serous we now consider black or white. Either you remove everything, or maybe you can consider stopping the surgery. In low grade, we can consider going even if we believe we cannot remove all the disease. And this is an interesting analysis about the chemosensitivity. I am talking about neoadjuvant chemo. You see on the left side, we have this graph showing 36 patients with low-grade serous cancer. On the right side, we have patients with high-grade serous cancer. The blue columns represent patients responding to chemo. The green represents stable disease. The orange, progressive disease. Look at the different patterns. It's visible, clear. Patients with low-grade ovarian cancer, they do not respond to neoadjuvant chemotherapy. So chemotherapy for low-grade serous is not the solution. And what about IPEC? Of course, I see that there is also discussion about IPEC later. IPEC is still an hot topic, hot also because the temperature of the IPEC is hot, but you see here that what we can retrieve from Van Driel's trial is not sufficient to take any conclusion, because there were just 6 patients with low-grade serous in that trial. So we don't have enough data to support IPEC. So IPEC for low-grade serous should be included within clinical trials. Medical therapy. Now, of course, I am a gynecologic oncologist, I say from the beginning of the slide, but what I understood is that chemotherapy is not an option. Look at this is a chemotherapy-resistant disease, you can see here, and you can see that the proportion of patients with high-grade serous responding to chemo, you see here complete response in 83% of patients, partial response 6%, so 90% has had some kind of response. Look at low-grade serous. 15% had complete response and 7% had partial response. So we are talking about 25% of the cases with response, meaning chemotherapy for this disease is not the answer. And a very recent, this was just published in International Journal of Gynecological Cancer. This is a very, very recent publication. It's a retrospective series analyzed by the National Cancer Database. And my colleague Dimitrios from Pennsylvania University showed that after adjusting for multiple variables, the adjuvant chemotherapy after the bulking for advanced stage low-grade serous ovarian cancer did not have any impact on overall survival. And it did also let's say, small meta-analysis here below regarding progression-free survival. And even in progression-free survival, there was no difference. You see all the confidence interval are crossing the 1. So the chemotherapy is not the answer. So medical oncology started to develop and think about other potential drugs. And one of the most promising one is hormone treatment, letrozole, for example. And you can see here the trial from Gershenson and also the data from Amanda Fader that's showing that actually if we do observation versus hormone treatment, there is a much different outcome in favor of hormone treatment. Despite this, I have to say, if we dig a little bit into the literature, this is true, but there is still lacking data on the use of hormone treatment for early stage disease. You see, in the ESMO guidelines, for example, patients with 1B1, 1C1, 1B and 1C1, and 1C2 and 1C3, they suggest for low-grade optional adjuvant chemotherapy. So we might think, let's give the hormone treatment here. But the data is quite scanty in the literature about that. But it's, food for thought, and it is a possible idea for next studies. There are, of course, ongoing studies randomizing patients to receive the standard chemotherapy versus hormonal treatment only. They are ongoing, and we really look forward to seeing the results. An open issue, I think, is this one. we said that go for surgery if you can, go for surgery even if you leave something behind. Of course, we have to deal with patients after surgery with residual disease. And this is an open issue, and it's an interesting issue. So we tried to develop it a little bit. In a sub-analysis of Gershenson trial from hormonal therapy versus observation, the hormonal treatment gave a benefit even in the patients with residual disease. We tried to do a retrospective analysis inside the Italian MEMAGO group and to look at the role of bevacizumab in patients with residual disease. So the question was, if we add bevacizumab to standard chemotherapy, do we give a benefit to patients with residual disease? And this is the situation. On the left side, we can see that there is a significant survival improvement if we give bev in the whole population with beva. On the right side, we have the stratification according to residual disease. And you can see that the addition of bevacizumab to standard chemotherapy gives a benefit even in patients with residual disease. So at least we have some kind of weapon in our hands. We also, thinking around the topic, we also developed another study. This is another retrospective, and we looked at a few patients with chemo alone, chemo plus bev, and chemo plus hormone treatment, and some of them with residual disease. And we can see here the curves. This is under submission, and there is not much significant difference, but we can clearly see that the patients undergoing with green treatment, which is chemo plus hormone treatment, the curves stays higher than the others. There are a couple of significance here if you dig into the p-values, but nothing major. But still, we see that the green line is staying high. So this is a result, the result that hormone treatment is working. There are a lot of ongoing trials. I don't want to bother you about this, but please I will look at the reference here, because this is the recently published consensus. I'm going to the end of the presentation, and I would like to talk about surgery for recurrence. As we said in the primary setting, the surgery is important, is crucial, even if we risk to leave behind disease. In recurrent disease is also important. This is a meta-analysis showing this concept. So the conclusion of the experts was that surgery, secondary cytoreductive surgery by gynecologists should be considered in any patients with this recurrence. Specific selection, though, criteria for secondary cytoreductive surgery in patients with low-grade serous carcinoma remain unclear. And this is still an issue. Probably this is still an issue, the selection, even in high-grade serous ovarian cancer. Of course, there is a lot going on with medical treatment for recurrent disease. In general, you can have hormone treatment, chemotherapy, anti-angiogenetic, target therapies. There are many different studies going on in recurrent settings. I just want to briefly going to show you a very recent study that we did at Gemelli, and it's just been accepted in International Journal of Gynecological Cancer. Very briefly, the concept was, the question was, is it safe and beneficial to do secondary cytoreductive surgery in low-grade serous ovarian cancer? So we compared a population of low-grade serous with a population of high-grade serous recurrent disease, of course, platinum-free interval. And for the survival, we did the matching 1 to 3. We did the propensity match. From the initial analysis before propensity match, we found that there were lots of difference in this kind of surgery. When you operate a recurrent low-grade or a recurrent high-grade, it's different. And the main difference were that there was higher complexity, multiple bowel resection, and higher median estimated blood loss in the group of low-grade serous. Meaning low-grade serous is more complicated to operate. It requires a bigger effort. But there was a comparable rate of postoperative complications. So with this, and with this showing that there is no difference in post-recurrence survival, we might conclude that secondary recurrent surgery for low-grade serous ovarian cancer could be an option that needs to be considered in this kind of patients. New frontiers, we already talked about hormone therapy, anti-angiogenesis, just a touch on this very important target therapy, which are the MAP, targeting the MAP kinase pathway, which we know are involving and activating the mutation of KRAS and BRAF. And there are many studies ongoing, but just to show you that one of them was closed earlier, the MILO study, because the progression-free survival hazard ratio crossed the predefined futility boundary. But when they did a sub-analysis, subsequent interim analysis, they found that actually there was a benefit, and the benefit was in patients with the mutation of MAP kinase pathway. On the right side, we have the very well-known and mainstay published, yes, time is up, treatment, with trametinib, use of trametinib by Gersenson versus standard of care, and trametinib was really successful in this study. This is the last slide, and I want to highlight that patient's perspective is important. It's crucial, and we need to hear the voice of patients. And this was also included in the consensus. For reason of time, I would like to read with you just the first and the last sentence. This is a survey sent to 71 patients. The first is, what are the most important issues? Patient says, treatment options, psychological and emotional support, very important, fertility options, and financial support, of course, mainly in America. The last question, I think it's very important, what would you say to doctors? And patients to doctors would say more time to listen, empathy, good attitude, honest, and informative. So really, I think this is very important because we need to create a connection, empathy with the patients and let them have the feeling that they are not alone. Concluding, low-grade serous is a rare disease. Lymphadenectomy in apparent early stage needs to be discussed with patients in view of the low risk of N+ and no survival benefit. Complete gross resection, possibly at PDS, should be the main surgical endpoint. HIPEC effect still to be determined. Surgery for recurrent might play an important role. Poor chemotherapy sensitivity, this is already well known, but consider hormone therapy, we've seen the advantages, and target therapies are promising agent according to biological status. With this, I would like to invite you all to ESGO Congress in Barcelona. It would be great to enjoy there together, and I thank you so much for your attention.